Hi, my name's Aram Hartung. I am a pediatric nephrologist at the Children's Hospital of Philadelphia, and I will be giving an introduction to ARPKD. I'd like to thank the PKD Foundation for inviting me to speak and all of you for being here today. So to start, I wanted to review my goals for today. So really, I'll be talking about all the different aspects of ARPKD, its effects on the kidneys, the liver, and beyond. But just remember that every child's ARPKD journey is different. So you or your child may not experience some of the issues I discussed today. And my goal is really to give general information and advice based on published research and personal experience, but this does not replace the expertise of the medical team that knows you or your child best. So I'll start by giving an overview of ARPKD, including the spectrum of disease, genetics, move on to how it might present in newborns and infants, talk about the effects of ARPKD in the kidneys, starting with just an intro to how the kidneys work and how cysts develop, and then ARPKD related health issues in the kidneys, as well as beyond, including high blood pressure and other issues. And then I'll talk about ARPKD in the liver, again, talking initially about what the liver does and how ARPKD affects the liver and what health issues can arise as a result. So to start with the spectrum of ARPKD and its genetics, so as you probably know, ARPKD is a rare disease. It's estimated to occur in about 1 in 20,000 births. So overall, we estimate that there's probably somewhere in the neighborhood of 1,500 children and young adults living with ARPKD in the United States. The disease can be very variable. It can be diagnosed at any time from birth to young adulthood. And the severity of the disease and kidney and degree of involvement of the kidneys and liver can vary quite widely. But overall, probably about a third of people are diagnosed either before birth or right in the newborn period. And then about 2/3 of people are diagnosed later in childhood or in adolescence. I wanted to show this to start. We'll go into each of these things in more detail, but I wanted to give you an illustration of the spectrum of ARPKD through the lifetime. And again, not everyone will develop all of these things, but there are certain issues that can arise before birth or at infancy that maybe get better or go away later in life. And there's some issues that usually develop later in life. And then again, for any individual person, you may or may not develop any of these issues. So I just wanted to give this as an illustration for some of the possible symptoms, and I'll talk about each of these individually, and then we'll return to this at the end. So to give some background on genetics, just briefly, each of our cells contains chromosomes, which within the chromosomes, those are made of basically coiled strands of DNA. And all DNA is a long series of letters. And you can think of DNA as being the instructions that our body uses to make everything, kind of like a book that contains a big instruction manual for our body. We inherit our DNA, about half of it from our mother, half from our fathers. And a gene is really like a chapter in that instruction book. And a genetic variant can be something like a spelling mistake or maybe a word or two missing, or sometimes even a chapter missing in that book. And that essentially makes it so that the instructions for that particular function in the body are different than somebody else's. Sometimes those differences can be harmless. For example, a gene that controls skin color or eye color or hair color. And other times, those genetic variants can lead to health problems. So in ARPKD, the difference is in a gene called PKHD1. The disease itself is recessive, meaning that in order to have the disease, you need to inherit the variant from both parents. So each parent will be carrying one of these variants. The parents themselves are unaffected. Having just one variant does not cause a problem. But if two people get together and each of them has a variant, then that could lead to ARPKD. So this diagram kind of illustrates how that could happen. Again, remember, this is a totally random process that's independent in each pregnancy or each child. So for example, in this drawing, if blue is the unaffected gene and purple is the affected gene, when you have two people get together, there's different combinations of how these genes can be passed along to the child. So if a child inherits both unaffected copies of the gene, then they would be healthy, they would not be a carrier. If a child inherits one copy of the variant gene and one normal copy of the gene, they themselves would be a carrier, just like the parents are, but they would not have any health problems. And then if a child inherits the variant that causes the disease from both parents, then they would have ARPKD and they would be affected. So how does ARPKD manifest in newborns and infants? So sometimes ARPKD is diagnosed on prenatal ultrasound, and some of you may have experienced this. Generally, the first major ultrasound in a baby is done around 18 or 20 weeks of pregnancy. And what people may notice is that the kidneys can be large and bright. The ultrasound term for that is echogenic, just that the kidneys look bright on an ultrasound picture. The amniotic fluid levels can be low, and that's because it's really the urine from the baby that makes the majority of the amniotic fluid later in the pregnancy. So if the baby's kidneys are not working well, then they may not be making enough urine. So the amount of fluid can be low. And then lung development actually depends on the baby kind of breathing that amniotic fluid in and out, and that helps to kind of inflate the lungs and helps them develop. And so if the baby's kidneys are not functioning well and not making enough urine, that can make the lungs underdeveloped. And then sometimes the kidneys are so enlarged that they're kind of squishing the lungs. And so that can also cause some problems with lung development. So in the newborn period, if the baby is one of more severely affected, there can be problems with breathing after the baby is first born. About 40% of babies will require a ventilator. Sometimes it's just for a day or two. Sometimes it can be for longer. Sometimes babies can develop a collapsed lung. Again, that usually is something that's treatable. But the breathing issues are really the thing that we worry about the most in babies. And so among the very severely affected babies, sometimes the lung development is so poor that it's not compatible with life, even with maximal medical support. So unfortunately, even in this day and age, about 1 in 4 babies who are born with more severe ARPKD unfortunately don't survive. Another issue that can arise in early infancy is sometimes if the kidneys are very massively enlarged, it can be pressing on the stomach and make it difficult to eat. And so sometimes babies will require a tube feeding, either an NG tube that goes through the nose and into the stomach, or sometimes a surgically inserted G tube that goes directly into the stomach to help trickle in formula and ensure that they're getting adequate calories. Sometimes if the kidneys are very massively enlarged, sometimes surgery is considered to remove one or both kidneys to try to make room in the belly. Of course, that can bring its own set of problems in terms of then needing to then replace that kidney function with dialysis. And there aren't really clear guidelines for what's the best approach. It's really a very individual decision based on the baby's individual circumstances. And so that's usually a decision that's made with the entire medical team, surgeons, intensive care doctors, nephrologists, to really make an individual decision for what's best for each baby. And again, remember, not every baby who has ARPKD goes through those issues. Even when they're diagnosed prenatally, some babies will have maybe just slightly enlarged kidneys, bright kidneys, and then they'll come out and be breathing just fine and do great. So again, that was just an illustration of what babies may experience in more severe cases. So to move on to kidney involvement, so we'll start with reviewing kind of kidneys 101, what the kidneys do, how cysts form, and then talk about kidney-related health issues. So the kidneys are two kind of bean-shaped organs located kind of in the upper back, kind of tucked under the ribs. If you were to zoom into each kidney, they each contain somewhere on the order of about 1 million of these little filters called nephrons. And those filters, essentially, you can imagine as blood flows into the kidneys, these blood vessels branch and branch, and each ends up going into these little filters called glomeruli or glomerulus. And this is where that filtration happens. And then the blood that gets filtered, this is kind of where the urine is starting to get made. And so the fluid that eventually becomes the urine travels through these tubes called tubules. And then these tubules all kind of get together like branches of a river that all then flow together and end up here in the collecting system of the kidney, and then flow down this tube called the ureter, and then into the bladder and out. So before I talk about how ARPKD affects the kidneys, I wanted to review a little bit about what the kidneys do. The kidneys actually have a lot of different jobs. Most of us are probably most familiar with their #1 job, which is getting rid of waste products from the body. But then they actually have a lot of other jobs, which really explains all the different effects that, that can happen in children who have kidney disease. Getting rid of waste products is the #1 job. Secondly, they are controlling how much fluid comes out. So obviously, if we drink a lot of water, our kidneys kind of take care of that by making us pee more. If we drink less, our kidneys hold on to more fluid. The kidneys are also balancing all of our different chemicals and electrolytes in our body, like sodium, potassium, bicarbonate, but again, by controlling how much they let go into the urine versus holding on to. The kidneys help to regulate blood pressure. And so we will talk about high blood pressure. Many of you have probably experienced this. And then they also make a hormone called erythropoietin, which is the hormone that tells your body to make red blood cells. So red blood cells are made in the bone marrow, but the hormone that tells the bone marrow to make that blood comes from the kidneys. And then the kidneys are also involved with activating vitamin D, which is that hormone, that vitamin that's really important for bone health. So vitamin D, we get it from our skin, we get it when exposed to sunlight, we eat it in certain foods, but it can't do its job unless the kidneys activate it. So chronic kidney disease, or CKD. So CKD basically means that the kidneys aren't fully able to perform all their normal functions. And so CKD is a very general term, and it can be caused by many different diseases, including ARPKD. And when we talk about kidney function, and I will talk about CKD stages that some of you may have heard of, what we're generally talking about is how well are kidneys doing that job of cleaning and filtering the blood. And we talk about this concept called glomerular filtration rate, or estimated glomerular filtration rate, or eGFR. And this is a way of conceptualizing how well are the kidneys getting rid of the stuff they need to get rid of. We estimate that in clinical practice using different blood markers. Most commonly, you're probably familiar with something called creatinine, and a somewhat newer marker is called cystatin C. But the concept with both of these chemicals are these are normal substances that all of our bodies are making constantly, but the only way our bodies have to get rid of these substances is through the kidneys. So we use these measurements of these levels in our blood to get a sense of how well are the kidneys doing that clearing and filtering job. Because if levels of the creatinine or cystatin C, if they're building up in our bloodstream, it means that the kidneys are not getting rid of those things fast enough. And so that just gives us a marker of how well the kidneys are filtering. The GFR number, you can think of it as being like a % kidney function. It's actually measured in this complicated unit that's related to the actual filtration, but the numbers very much track with as if it were a % kidney function. And so what that translates to is, you may have heard of this concept of CKD stages. And this is just a way to kind of conceptualize where somebody is on that spectrum of kidney disease. So if you have kidney disease or damage, so say you have a diagnosis of ARPKD, but your kidneys are actually filtering normally, so your kidney function is between 90 and 100%, you would be called CKD stage 1. And then as kidney function decreases, people may advance through these different CKD stages. So stage 1, stage 2, stage 3 is divided into A and B, stage 4 and stage 5. And these correspond to different decreasing levels of kidney function with the numbers shown here. And then kidney failure is really when that kidney function gets less than about 15% or so. And that's when we really, for many people, that means when they might need dialysis or kidney transplant, which I'll talk about a little bit later. So what is a cyst, and how do those cysts develop in ARPKD? So a cyst is all it is. It's a fluid-filled structure, kind of like a water balloon. And the reason why cysts might grow in the kidneys is two things. If you think about the way a water balloon might inflate, two things need to happen. One is that the wall of that balloon needs to be able to expand and grow. And the second is there needs to be fluid building up in those cysts. So what that looks like, if you remember in that previous picture, I showed you these filters called nephrons, which are, remember about 1 million of these in each kidney. So this is that glomerulus. These are those tubules that are in the kidneys. What happens with ARPKD is this end part of the tubule called the collecting tubule, because that gene is not working properly and doing its job of keeping that tubule in a nice tubular shape, these tubules kind of get dilated, the walls of these tubes kind of expand, and there's fluid kind of collecting in there. But there's still fluid flowing through, but then as these cysts expand, they can kind of, they really impair the function of the kidneys, because they're essentially, if you can imagine all of these millions of filters, if they all have these dilated tubes, they kind of start to squish each other and not allow them to do their jobs properly. So what that looks like in a kidney, this is an example of a kidney that's been removed. That on the left side is a normal kidney. The colors are a little different just based on the preservation of these particular samples. But the main thing I wanted you to see is really these tiny little bubbles kind of throughout the kidney. And this is really showing that, if each of those kind of tubules, when they dilate like that, they make these tiny little cysts. What you may be more familiar with is what it looks like on ultrasound. And so on an ultrasound on the left side, this is what a healthy kidney would look like. It's kind of bean-shaped. It's kind of a dark gray with some even darker areas in certain places, and then sometimes a little light area in between. Whereas in ARPKD, the kidney itself might be much larger than normal. And then instead of having that nice kind of dark gray appearance, you can see that there's just almost the salt and pepper type appearance to the kidneys. The cysts themselves are usually too small to be seen individually, but if you use your imagination a bit, you can see a little bit these dark spots. Fluid shows up as dark on an ultrasound. So these little dark black areas are little fluid-filled bubbles that are really those cysts throughout the kidneys. So what are some of the issues that ARPKD causes in the kidney, and how does that affect the kidneys themselves as well as lead to effects outside the kidney? So I will talk about kidney function electrolytes, infections, high blood pressure, cardiovascular issues, anemia, bone health, and growth and development. So to talk about kidney function first. So as I mentioned before, there's a huge range of severity of kidney disease. Some people will experience decline in kidney function and even kidney failure very early in life. And then for some people, that may not happen for many decades. And so it is somewhat dependent on age at which the symptoms develop. In many studies, what people will do is they'll look at the difference between people who presented very early in life, like when they were newborns, versus those who presented later in life. And so this graph here comes from a study that was done at the NIH a number of years ago of about 70 or so patients. And they they looked at the age at which kidney failure developed based on the age at which the person was first diagnosed at ARPKD. And so this is so these are survival curves. Essentially along the bottom here, you have age, and then kidney survival basically just means people who have not yet developed kidney failure. Doesn't necessarily mean the kidney function is normal, but it just means they have not yet needed dialysis or a kidney transplant. And so the blue line here shows people who were diagnosed in the perinatal period, meaning that it was either during pregnancy or in the first month of life. And you can see that in general, every time there's a step down, it means a person has developed kidney failure. So that really you can see here this line that I've drawn. The way you interpret this is that if you want to find out when 75%, or when 25% of people had developed kidney failure, meaning there's still 75% of people who had some degree of kidney function, that age is around age 11. So yes, it's early in childhood. There's certainly many children who will develop kidney failure early in childhood, but even among kids who are diagnosed with ARPKD either before or right at birth, many of them will still have intact kidney function into early childhood. Whereas in folks who develop symptoms later, about 75% of them will still have some degree of kidney function even into their 30s. And so again, this is really a very wide variety of ages at which people develop kidney failure, and there's and we aren't great at predicting when an individual person will develop kidney failure, but a lot of it has to do with how quick early in life you can start to see people who might have kidney function that's impaired early in life. They will obviously be at higher risk for having that kidney function decline over their lifetime versus someone whose kidney function stays reasonably normal for the first few years. So as I mentioned before, the kidneys are also involved with regulating your electrolytes, your water balance. And so some of the issues that can develop in ARPKD, which are common to other kidney diseases as well, is sometimes the kidneys aren't good at getting rid of acid. And so you'll see that on blood work with a number called bicarbonate or carbon dioxide. And that can be low if your kidneys aren't getting rid of acid. So some children will need bicarbonate or citrate supplements, which are kind of like a medical form of baking soda to help balance the acid in the body. Some people will have low sodium levels. This really is something that happens kind of early in infancy and then tends to get better. We don't fully understand why, but it might have to do with not being able to get rid of enough water. And so you have kind of too much water relative to sodium in your body. And so some solutions for that can be to try to decrease the amount of water in feeds by giving more concentrated feeds, by giving a medicine like Lasix to help get rid of extra fluid. Sometimes sodium supplementation is given to try to boost those sodium levels, but you have to be a little bit careful with that because sometimes that can make the blood pressure worse, but it is needed on occasion. And then the flip side of that is often later in life, the kidneys might actually have trouble holding on to water. So many people with ARPKD will make larger amounts of urine than normal. So you may have noticed this with yourself or your child, that you might pee more than other people. Many children with ARPKD will have issues with bedwetting. And because the kidneys aren't good at kind of doing that job of holding onto water when they need to, people with ARPKD can be at higher risk of dehydration. And so they always want to just have good access to water, making sure that they're staying on top of their water drinking, and really keeping up with water that might get lost in the kidneys. So infections. So there is an increased risk of urinary tract infections in people who have ARPKD. Probably somewhere between 20 and 50% of people may have UTIs. We don't exactly understand why, but it may have something to do with the fact that when those tubules are dilated, like that picture I showed you before, that the urine just isn't flowing through as smoothly and as quickly as it should. And so that can just be a place where infections can develop. But there can also be infectious issues outside the kidney. There can be bile duct infections, which I'll talk a little bit more about in the liver section. And then just in general, when kidney function is impaired, it affects the immune system in a lot of different ways. And so this is for anybody who has kidney disease, not just ARPKD. We recommend that children complete all their childhood vaccinations, get their flu shot, get a COVID vaccine if they're eligible. And then there's an extra vaccine called Pneumovax, which is recommended for children with reduced kidney function or liver disease that can be given at age 2 and up. And this is the same as if you've heard of older people getting their pneumonia shot. It is the same vaccine, and it's recommended for children as well with certain health conditions. So to talk about dialysis, so recall this is something that we may consider when that kidney function gets to less than about 15% or so. So dialysis is a procedure that's used to replace some of the functions of the kidneys after they fail, and really mainly those functions of removing waste products and extra water and balancing the electrolytes. So the first type of dialysis is something called peritoneal dialysis. So this is done by a child would have a catheter that's surgically inserted into the abdomen. Here in the top left is a G tube. This is a feeding tube, but the PD catheter is the one that you see here on the child's lower right side. And the way this works is that the child would get hooked to a machine that looks like this every night. And the machine uses this fluid here that gets the machine kind of pumps the fluid into the abdomen. The fluid kind of absorbs waste products, impurities, extra water. And then there's, it's not shown in this picture, but then there's a kind of waste bag that the kind of dirty fluid gets put into. And so the machine overnight will pass fluid in and out of the child multiple times per night to help get rid of extra fluid, waste products, and that's what accomplishes those jobs of the kidneys. Occasionally, because this involves fluid needing to be put into the belly, if the child's kidneys are very, very large, the kidneys may need to be removed in order to have enough room to do this in the belly, but that's not always the case. The other way of doing dialysis is one that's more common in adults, but we do use it in children as well. And that's blood dialysis. This is the type of dialysis where, if you've seen dialysis centers around, or if you know someone who goes in a few times a week for dialysis, this is generally the type of dialysis they're talking about. And this involves having the blood taken from the body, being passed through a machine that cleans and filters the blood, and then having that clean blood returned to the body. And this requires some way of getting the blood from the body, either a catheter, which is like a large IV, or sometimes a special surgery is done to create a larger vein called a fistula that can be used to get to the blood. And in this case, the child may come to a dialysis center at a hospital or clinic, and it's generally around 3 to 4 times per week for about 3 to 4 hours at a time. And then kidney transplantation, this is something where this can be done from either a living or a deceased donor. So in this illustration, it's really the same procedure regardless of whether it's a deceased or a living donor. The kidney is removed from the donor and put into the recipient. In many diseases, the original kidneys are usually left in place. However, in children with ARPKD, sometimes if these kidneys are so large, there may not be enough room in the belly to put yet another kidney into the belly. But generally, the transplant kidney isn't put in the same place where the native kidneys are. It's usually connected lower down in the abdomen, often kind of to these lower blood vessels here in the pelvis, or sometimes to the aorta and IVC in the abdomen. And there is, in order to do a transplant, there's a lot of testing that needs to be done to make sure that the donor and recipient are compatible with each other with respect to blood type and tissue type. If it's a living donor, there's a lot of testing to make sure that the donor is healthy enough to donate and that it wouldn't adversely affect their health to donate a kidney. And then there's a lot of testing of the recipient to look for any potential problems, infections, or other things that may put them at risk for during the surgery or from the medications that are needed afterwards to prevent rejection. I did mention already that the kidneys may need to be removed in children with ARPKD. And then really transplant is something that requires lifelong care. There's medications that need to be taken lifelong on a very strict schedule to prevent rejection. But overall, the quality of life with a kidney transplant can be very, very good. Transplanted kidney, if you take good care of it, can last for 10 or 20 years or more. But even with it lasting that long, for most children, if they do get a kidney transplant during childhood, most children will need another transplant at some point later in their life, sometimes more than one more transplant, or there may be times where, say, their kidney transplant is failing and they may need to go on dialysis while waiting for another kidney transplant. So let's move on to ARPKD outside of the kidneys. So many of the issues outside of the kidneys do originally stem from the problem that's in the kidneys. But again, because the kidneys have so many different jobs, it affects the body in many different ways. So the most common issue, and this is probably something that almost all of you may have experienced, is high blood pressure. High blood pressure or hypertension. In younger children, what defines high blood pressure is based on percentile. So you're familiar with percentiles, say, for height or weight. Similarly, for blood pressure, there are complicated tables that tell us what blood pressure should be based on the child's age, sex, and height. And that's for children less than 13 years old. And then once you get to 13 years and above, you start to use the adult numbers. And so what's defined as hypertension is if somebody's blood pressure is greater than 95th percentile, if they're less than 13 years old, or for in the adult world, it would be, or for children aged 13 and up, that would be if the blood pressure is greater than or equal to 130/80. Most often hypertension does not have any symptoms. And so that's usually something that would get picked up, say, on a regular checkup or when you go to the nephrologist's office. If the blood pressure gets very high, there can be symptoms like irritability, visual changes, headache, but that would really be if the blood pressure is very elevated, and those things can be things that need to be taken care of more urgently and might require hospital-based care. So hypertension can develop even when kidney function is normal. So, those cysts can be there in the kidneys and the kidneys might still be filtering fine, but because of the presence of those cysts, it does kind of make the kidneys make more of these hormones that help to raise the blood pressure. Overall, the vast majority of people with ARPKD will have high blood pressure, about more than 85%. Sometimes it can be very difficult to control. So about a third of children with ARPKD need 3 or more blood pressure medications. And the most common medicines that we use, you might have experience with medications in a class called ACE inhibitors, like lisinopril or enalapril, or a related class called ARBs. And these are often preferred because they work directly on those hormones in the kidneys that raise the blood pressure, and they're thought to protect the kidneys in the long term. They can make potassium levels go up, or sometimes even the creatinine level go up. So they may not be appropriate for all patients, but we do often prefer them if able. But there's many other blood pressure medications that can be used in children safely, like amlodipine, labetalol, clonidine, many others. And again, some people may require multiple medicines to get the blood pressure under control. So moving on to cardiovascular issues. So we all know that good blood pressure control is very important for heart health and important for kidney health. And we do keep an eye on the heart often to make sure that problems such as thickening of the heart muscle or left ventricular hypertrophy isn't developing. And that's something that can develop if blood pressure is not well controlled, but it can get better if the blood pressure is got under better control. I will mention aneurysms. This is something that we don't know much about in ARPKD, but you may have heard or read that people with the other form of PKD, not ARPKD, but ADPKD, which is the disease that is more common in adults, that there is a higher risk in the other form of PKD for brain aneurysms. An aneurysm is basically just a ballooning of a blood vessel. And this is something that's known in ADPKD, the other type of PKD, and it's been reported very rarely in children and young adults with ARPKD. There's been, in the last 25 years, there's been 7 patients who have been reported in the literature to have brain aneurysms and 2 with aneurysms in other part of the body. But again, this is extremely rare. We don't know that much about this yet. So as of right now, there aren't general recommendations to go looking for these, but this is an active area of research, and we are actually doing a research study at CHOP to learn more about this. And so this QR code, you're welcome to scan if you're interested in learning more about the study, and I'll put this up again at the end if you're interested in learning more about this research. So moving on to anemia. So you may recall that I had, so anemia overall is having low hemoglobin or red blood cells. So you recall that I mentioned this hormone called erythropoietin, which is made in the kidneys. And if people with more advanced kidney disease can have low levels of that hormone and can become anemic. The other thing that can happen is the kidney disease also affects the way your body handles iron. And so it's common for people with kidney disease of any kind, including ARPKD, to need iron supplements. And then sometimes, particularly with more advanced kidney disease, people may need injections of erythropoietin, sometimes called EPO for short. And that's injections that might be given once a week or sometimes more or less frequently to help boost levels of that hormone. In ARPKD liver disease, there's a couple reasons that people can develop anemia. If the spleen is enlarged, it can kind of trap red blood cells. And then there is a risk of bleeding from varices, which I'll talk a little bit more about later. Bone health. So as I mentioned, the kidneys activate vitamin D, which is very important to keep bones strong. And for bones to be strong, they need calcium, they need phosphorus, they need vitamin D. And there's another hormone called PTH or parathyroid hormone that's released from glands in the neck. And all of these things are things that nephrologists often monitor in people with kidney disease. And so there's different types of issues that can arise related to bone health. Some children might have high phosphorus levels and need to either be on a phosphorus restricted diet, or be on a medication that helps to prevent absorbing phosphorus from the food, so phosphorus binders. Some people can have low calcium levels and might need calcium supplements. Some people might have low vitamin D levels and might need vitamin D supplements, sometimes just a regular vitamin D, or sometimes a form of vitamin D that's already been activated, so that if the kidneys can't activate it, you can take this medicine that kind of is already activated. And high PTH levels are really treated mainly with that activated form of vitamin D. And then growth and development. So growth problems are very common in children with chronic kidney disease from any cause, including ARPKD. We actually did a study to try to figure out if the degree of growth problems in ARPKD are any worse than in children with other forms of CKD. And we found that in general, when we did these matched comparisons with children who had other forms of chronic kidney disease, that in general, the level of growth problems as a group is fairly similar to people who have other causes of CKD, but overall we do know that kidney disease can affect growth, and that's something that we pay close attention to as we take care of children with kidney disease. Some children with kidney disease can also have learning difficulties. And again, we did a similar kind of match study where we looked at children who had ARPKD and compared them to children with other congenital causes of CKD. And again, the degree of learning differences are similar in ARPKD compared to children with other types of kidney disease, but overall, the scores are a little bit below average compared to healthy children. But again, there's a lot of variability. Some children will have more severe issues, some children will have no issues and be doing just fine, but it is something to pay attention to and get help for if needed. So moving on to the liver. Just liver 101. So the liver is up in the right upper quadrant of the abdomen. It has a lot of different jobs, but some of the jobs it does, it creates this green substance called bile, which you can kind of see these, in the shadow here, there are these ducts that as the liver makes bile, it flows down these ducts. It can collect in this organ called the gallbladder, which kind of stores the bile. And then that tube, the bile ducts, connect to the intestine. And that bile kind of contains some waste products that your body needs to get rid of. It also contains different chemicals that help you to digest your food. The liver also helps to metabolize all kinds of, really all the chemicals in our body, fats, proteins, carbohydrates. So all of the, when we eat and we're absorbing nutrients from our intestines, all of that blood kind of goes through the liver, with the liver does its thing and takes those nutrients from our food and converts it to things that our body needs. The liver also is involved with getting rid of certain toxins and with metabolizing certain medications. So in ARPKD, there's three main issues that arise in people who have ARPKD. So one is that those bile ducts, so those were those tubes inside the liver that kind of carry the bile, those can be enlarged. The liver itself, so meaning the meat of the liver, can become scarred and stiff. If you remember, I mentioned that the blood flow from the intestines and other internal organs normally flows through the liver through a system called the portal circulatory system. And when that liver becomes scarred or stiff, then the blood that's returning from the intestines and other areas internally, it can't flow easily through that portal vein system. And then that can cause high blood pressure internally in the portal vein system. And I'll show a picture that illustrates that a little bit. But again, just like the kidney disease, the severity of liver-related symptoms is very variable. Almost everyone will have something that you can maybe see on an ultrasound. Maybe the liver looks a little irregular. And so on a microscopic level, the liver is never completely normal, but some people never develop any symptoms at all related to the liver, and other people can develop more severe complications. And there isn't really a clear relationship between the severity of kidney and liver disease. Some people can have very severe of one and not the other. Some people will have severe involvement with both. Some people will have mild involvement with both. And so that's something that needs to be looked at individually for each child. So just to show a little bit more about what I was talking about. So this is a picture just for illustration purposes. So on the right, in this section of the liver, it's showing what a healthy bile ducts might look like. And on this side of the picture, it's giving an illustration for what dilated bile ducts might look like in a disease like ARPKD that causes dilation of the bile ducts. And then this picture here illustrates what portal hypertension is. And so if you recall, I mentioned that the blood from our intestines and other internal organs, including the spleen, all it flows back into the liver. And so this diagram is showing what might happen if that liver is scarred and stiff. So if you have liver fibrosis, which is just a word for scarring, and that blood can't return properly from the spleen and other organs, and it can't flow back into the liver properly. So this ends up being a little bit like a dammed river where you have kind of blood collecting upstream because the flow of that blood is not perfectly smooth through the liver. And the main issues that arise there in children or adults who have ARPKD is something called varices, which is basically blood vessels or veins that are around the esophagus, the lower part of the esophagus, right where it meets the stomach, or in the stomach itself, that they become dilated and at risk for bleeding. And then the spleen, which is an organ that sits on the left side of our bellies and has a lot of different jobs, but particularly one of its jobs is to kind of clean and chew up old blood cells that we don't need anymore. And that spleen can get enlarged just because it's kind of getting engorged with blood. And when that happens, that spleen kind of chews up blood cells more than it should. And so this table here kind of illustrates the spectrum of what people may experience with liver disease. And so again, it can range from having no symptoms at all to having severe symptoms. And I divided this up into the three parts of liver disease, but all of these can kind of coexist in the same person. The bile duct dilatation, so some people that might be normal. In some people, you might see that the bile ducts maybe look a little enlarged on ultrasound, but maybe they don't have symptoms. Some people, those dilated bile ducts can get infected, and that's something called ascending cholangitis. And that can manifest as having fever, belly pain. And so that's always something to think about in a child with ARPKD who might have fever and belly pain. And then some people might have more recurrent severe infections, so that can cause more chronic health issues. With the fibrosis, that's that concept of the liver becoming stiff and scarred. In some people, the liver might appear normal, or it might appear a little bit irregular, but they might have no symptoms. But in other people, as if the disease is more moderate or severe, the liver might be enlarged, and then that stiffness may impair the blood flow through the liver and cause portal hypertension. And then with portal hypertension, again, if you don't have portal hypertension, then everything's flowing just fine. The symptoms that people may develop with portal hypertension, mainly it's related to when that spleen gets larger, it starts to eat up some of the blood cells, particularly the platelets, which are the little things in our blood that help our blood to clot. And so some people, when the spleen starts to get enlarged, they might have low platelet counts. And then sometimes as the spleen gets more enlarged, it starts to also kind of eat up some of the white blood cells as well. And then because of the blood flow being impaired from the esophagus and stomach, those veins that I showed you on the previous picture, the veins around the base of the esophagus where it meets the stomach can get dilated, or in the stomach itself, and those are at risk for bleeding. And some people that can be more severe and they can have bleeding over and over again. And so the treatment really depends on the degree of symptoms. For many people, they have no symptoms at all. And so, so as they go to the doctor and they're getting their blood work done, the platelet counts are part of the regular kind of CBC that people will often get. And so that's something that the doctors will be tracking. If someone's getting infections of the bile ducts, that ascending cholangitis, they might need antibiotics. If someone has varices, they may, which are those dilated bile ducts, dilated veins in the esophagus and stomach, they might need endoscopy, which is putting a camera into the esophagus and stomach to find those veins and either kind of inject them to make them shrink away or put a little band around them to make them disappear. And then in some people with very severe liver-related issues, they might need shunt surgery, which I'll tell you a little bit more about in a second, or liver transplant. And so shunt surgery is needed in about between 10 and 40% of people, depending on what study you look at, and liver transplant is between 7 and 13% of people. And so this just gives a bit of a cartoon for what a shunt surgery is. Again, it's really just that idea of, if there's a traffic jam in the liver for that blood flow, it's creating a detour around that. And so this is a picture similar to the one that I showed before, where if the liver is diseased and the blood is not flowing back from the stomach, spleen, and other organs properly, then what a shunt does is it takes, this is a surgical procedure where you can take one of those veins, often the vein from the spleen, and connect it to the regular circulation. In this case, this is the vein from the kidneys. And so that instead of the blood needing to go from the internal organs through the liver before it goes to the rest of the body, you take that blood and put it directly into the regular circulation, not the portal circulation. And that helps to kind of bypass that impairment of blood flow in the liver. There's also a non-open surgery way of doing this, something called a TIPS procedure, where this is done kind of using a catheter that is put in, similar to if you've known people who've had like a cardiac stent put in, where a catheter is put in through a vein and they're able to kind of from the inside thread a catheter into the veins and create a connection in the liver that kind of bypasses some of those smaller veins that are not allowing the blood to flow through the liver properly. And then liver transplantation, similar to kidney transplantation, it can be done from either a deceased or a living donor. As I mentioned before, it's somewhere in the neighborhood of 10% of kids with ARPKD, or kids or adults with ARPKD, may need a liver transplant. And the main reasons for needing a liver transplant would be if somebody has such significant portal hypertension, like say they're having bleeding over and over again, that can't be controlled by doing those endoscopies. or if they're having recurrent bile duct infections that they're needing antibiotics over and over again. So those are really the main two reasons why people might consider liver transplant in people with ARPKD. And then timing of a liver transplant relative to a kidney transplant really varies. And that, again, because the kidney and liver disease are almost independent of each other, there are some people who just need a liver transplant and their kidneys are fine. There's other people who might need a combined kidney and liver transplant at the same time. There's people who might get a kidney transplant first and then their liver is okay, but then many years later, maybe they need a liver transplant. And so all of those decisions for which organ transplant somebody needs and the timing and all of those things are things that really need to be discussed on an individual basis. And so we do a lot of communication with our liver transplant team to really optimize and individualize the approach for each person. So the liver transplant itself, as I mentioned, it can be from a deceased donor or a living donor. If it's a living donor, of course, it cannot be the whole liver, but they would take a segment of the liver. And then, you know, the details of how those decisions are made are a little bit beyond my area of expertise as a kidney doctor. But just know that if a combined kidney liver transplant is being considered, that almost always has to come from a deceased donor, because generally it's too much on a living donor to take a portion of the liver and the kidney. So finally, to wrap up, I'll just return to this illustration that I had shown you at the beginning. And again, just to illustrate that ARPKD, there's a lot of possible symptoms, but again, not everyone will develop all of these issues. The symptoms that someone develops vary throughout the lifetime. And again, not everyone will develop all of these things. But in general, enlarged kidneys, bright kidneys, decreased kidney function, those can be present right from birth or may develop at any point in the lifetime. Enlarged kidneys tend to be there more so in early childhood, but they don't necessarily continue to grow through adolescent and adulthood. If someone's more severely affected right from before birth, they might have that low amniotic fluid and underdeveloped lungs. But often, you know, that is something that even if they might have breathing issues in the newborn period, that those often do get better later in childhood. Feeding difficulties, as I mentioned, tend to be more of an issue earlier in life and can often tend to get better with age. Those low sodium levels that I mentioned tend to really only be a problem in infancy, and people grow out of it. High blood pressure can really be an issue at any age, can start right from infancy or sometimes later. And then the liver involvement tends to develop, it's very uncommon in infants, but tends to develop later in childhood, adolescence, or maybe even adulthood. So really the key things that I'd like for you to remember are every child's ARPKD journey is different. And because of all of the possible effects that ARPKD can have, it's really important to have a good team of doctors. You'll nephrologists or kidney specialists, hepatologists or liver specialists, and then often other team members as well, depending on the extent of your child's involvement with different issues. And living with ARPKD can involve many challenges, but we're learning more and more each day. We're learning how to better take care of these children, and children with ARPKD really can lead happy and fulfilling lives, even while dealing with some of these medical issues. And then just finally, if any of you are interested in learning more about the active research studies that we have going on at CHOP, you're welcome to scan either of these QR codes. We have an active study that's looking at that aneurysm or a blood vessel issue, and then another study that's looking at liver issues. Or you can email my study team at this ARPKD_studies@chop.edu email address. So thank you for your time, and I hope you enjoy the PKD Connect conference.